Hi, Kumar Madasari here from Rush Medical Center, Vascular Interventional Radiology. Thank you for joining me. The question for this topic is DCB plus bare metal stent equals drug-eluting stent, and it's an interesting question. Disclosure slide for me. The answer is no. Thank you very much. It's been a pleasure. Just kidding. Maybe not. Let's look at where the problem lies in this. How do we get here? So plain balloon angioplasty, POBA, seemed like a great idea a long time ago when we started endovascular interventions, and actually for some people still seems like a good idea, even though I think we know better that just POBA alone for a lot of heavy disease is not significant. Pump it up, pull it out, next case. It's an easy way, but I think we know that TLR and all those get affected significantly by just POBA alone. We know enough about the dissections we create with it, the recoil of vessels that we commonly see, which sometimes require stents or other adjunctive treatment. And we know that just touching with the balloon in any way starts the hyperplasia process, so that's something we're aware of. So placing a scaffold inside it, since POBA is not the greatest, seemed like a good idea. We know for bare metal stents that in-stent restenosis becomes kind of a pain to deal with, but it's something it's real and expected. A lot of stents have considerable variations in their designs, their components, the way they open, the way they deliver. So we know a lot about bare metal stents. It's still kind of a commonplace, especially in the drug-eluting controversy era. So it's still something that we need to be aware of and prevalent. So I think scaffold came in as a way to assist the POBA situation. Then they thought, well, what about putting drug on the stent to help prevent some of the issues we deal with stents? Meaning, can we reduce the hyperplasia that happens once you do damage to a vessel, and will that help your patency and longevity? The stents already help with the elastic recoil and dissections, and by having the drug on the stent, you can slowly elute the drug to the injured vessel wall. It's been shown many times over by Dr. Dake and all that about the study with the Silver PTX and how well it helped from a drug-eluting stent versus bare metal stent situation. Problem with just having that alone is that you can't always put the scaffold everywhere. They can get fractures and thrombosis depending on where they are and the blood flow, the outflow and all that. And there's some people who like slogans saying no metal behind, et cetera, et cetera. So there's a lot of issues where you can't just rely on that, and we know there's some issues currently with the controversies and how do you navigate that. So then, the thought, well, as technology evolves, is why not balloon with the drug as well? So you got DCBs. The balloons are coated with different carriers to help deliver the drug to the vessel wall, and how long and how much drug is there is what kind of changes between the different devices. Is it the best of both worlds? You get local delivery of the drug to help reduce the hyperplasia. For those critics or those thought process people, you're not leaving metal behind, and they had above and below the knee, but then we ran into some controversy, so this is all being negated a little bit right now, so it's a little tough. The famous battle is DCB versus DES, and we don't know definitively what the answer is. We know that if you're using them, know how to use them where and when in your own practice and your own outcomes, and until we have a head-to-head of everything, we don't know an answer to it. What do we know? You get meta-analysis, meta-headaches. We're all in limbo currently, and it's up to operator choice to be very selective with their patients and protect themselves and the patient as well as best we know how. So does a DCB plus a bare metal stent have value? I don't know if it matters right now. I think the mechanisms of effect are clearly different between a bare metal stent, drug-coated balloon, and a drug-eluting stent. Just saying that you drug coat the whole vessel and then you bare metal stent the whole vessel, it's a nice idea in theory. I don't know if there's much to it yet. There is some data. We have a couple studies as well as others. There's two of the ones just happen to pull up. The DBAS, which is a self-expanding stent with drug-coated balloon, 65 patients with the bioelectronic systems. The rationale was to primarily stent and then drug-coated balloon. That the drug-coated balloon through the stent can be almost like a scoring effect, and you can see the data here from their own data set out to 24 months and their primary patency out to 24 months of 88%. There's also the BioLux Forever, started with 120 patients. It's full drug-coated balloon followed by full bare metal stent. They show the primary patency at 12 months was about close to 90% and 83% for the remaining 105 patients that were followed up to 2 years. So this has been presented before, as you can see in the reference. Is there a PTX effect if we prepare the vessel with drug-coated balloon and scaffold the stent afterwards? You can see here between the two options that there was an increase of 8% at 12 months and about 11% at 24 months. So there is some effect there. There's also some people who've looked at DCB then Sapera. Anish Thomas has looked at this, presented a link before. Single center experience with 40 patients, and at 3 years had 17 patients follow up. You can see the outcomes up to 12 and 36 months here in terms of patency. How did it compare when you combine the Paseo-Lux and the Pulsar, showing 12 and 24-month outcomes in the SFA compared to drug-eluting stent? What the basic summary says, presented a link by Dr. Luce, is drug-coated balloon, then bare metal stent, or bare metal stent, then DCB did well. And I put that quotation mark because it did well. I don't think it proved that it did any better. It kind of said that it's similar to drug-eluting stent. So why do both? If you believe in drug-eluting technology, choose one or the other, or neither, based on what you think is right adjunctive treatment for your patient. It's all about patient selection. In this controversial era, I think we don't have a lot to guarantee anything or have a great idea what's going to happen. So I think patient selection, discussion, and being willing to bring them back and make that final decision may be prudent in some of these situations. Is there something better out there? Bioabsorbables, maybe that has a chance of coming back. Some of us are getting excited that there may be, and we'll see what happens with that. What is the best? Best for the patients to never need a procedure at all. Unfortunately, the clock's already started once we even contemplate intervening. We're catching these patients far too late in the process. What we do need is better data, predictive models, and maintenance of care for these patients. We're going to have all these little questions about these devices or that device, but I think in the end we have to do a better job of a global care of the patient. What we need is that holy grail, a randomized control trial telling us what the answer is. We're not there yet. Maybe we'll get there at some point, and I hope we have better answers at that point. Until then, pick and choose your drug-eluting technologies, patients wisely. Maybe consider DCB when you don't need a scaffold. Maybe consider a scaffold when you need a scaffold. Maybe both if you feel that's good. But we don't have data to tell us what to do, so I think we're in a flux. There is more data coming out little by little, and once we get to a randomized blinded control trial, we might know better. Till then, there's people doing studies on animals, as you can see here in Journal of Endovascular Therapy of Zilver PTX, followed by drug-eluting balloon dilatation in swine models. Showed it can be a potential safe strategy if you need it, and we'll see. There's more to come, and thank you so much.